So let's talk about hypermagnesemia. Hypermagnesemia is not much common in intensive care, but it can be found or we can encounter such cases in CKD patients. So magnesium mostly dealt by kidney. It has enormous capacity to excrete the magnesium. So hypermagnesemia is nothing but it is amount magnesium level more than 4 milliequivalent per liter. Hypermagnesemia mostly encountered in CKD patient and renal dysfunction. Clinical features of hypermagnesemia depend upon the serum level of magnesium. Um, More than 4 milliequivalent causes hyporeflexia. More than 5 milliequivalent per liter causes first degree heart block. More than 10 milliequivalent per liter causes complete heart block. More than 15 milliequivalent per liter causes cardiac arrest. Basically, magnesium is a physiological antagonist of calcium. So whenever there is increase in magnesium level, calcium physiological effects are decreased and it causes symptoms and signs of hypocalcemia. So, so in clinical feature there can be hyporeflexia. It is the first, in fact it is first clinical feature. Then there is weakness, lethargy, paralysis and somnolence. Respiratory failure is there because of diaphragmatic involvement. In cardiac signs and symptoms there is hypotension, bradycardia, cardiac arrest. If you see ECG changes in hypermagnesemia, there is prolonged PR interval, prolonged QT interval, broad QRS complexes, and whenever the level is more than 50 milligram per liter, there is complete heart block. So normal serum magnesium level, the window is 4 to 7 milligram per liter. For monitoring hypermagnesemia, when we are giving magnesium sulfate to eclamptic patient, we usually monitor respiratory rate, which should be more than 12, urine output, which should be more than 30 ml per hour, more than 30 ml per hour, or 0.5 ml per kg per hour. And the reflexes we see for Niger reflex for monitoring magnesium level. So what is hypermagnesemia evaluation and management? So exogenous sources are there and exogenous administration, that is iatrogenic administration of magnesium causes hypermagnesemia. So there is hypermagnesemia in decay, tumor lysis syndrome, theophylline intoxication, adrenal insufficiency, primary hyperparathyroidism. Iatrogenic cases, there is administration of antacid which contains magnesium sulfate in CKD patient, magnesium containing laxatives given to renal patients, those who are in renal failure. In eclamptic patient, when we use magnesium sulfate, there can be overdosing and magnesium toxicity. So what is treatment of magnesium toxicity? Already we have talked about the physiological antagonism of magnesium. It antagonizes the calcium effect. So first of all, we should stop additional magnesium which is given being given to patient. If there are ECG changes, we must give calcium gluconate 1 to 2 gram over 10 minutes. And if patient is in CKD patients and the symptoms are not controlled using the calcium, we must do dialysis. We can use Lasix furosemide, which causes forced saline resuscitation of forced saline diuresis. Furosemide causes loss of magnesium, then calcium, potassium, sodium. So it causes natriuresis and decreases serum level of magnesium. Okay, thank you.